All right. Welcome back, clinical problem solvers. It is great to see you again. This is Jack here. And today we are going to take a dive through some of the different clues that can tip us off to whether or not a patient possibly has infectious aortitis. So, just to sort of situate ourselves in terms of where we're at with this schema, we're going to use this schema in a patient who we discovers has aortitis. In other words, we see signs of inflammation of the aorta, usually on imaging like a CT scan or an MRI. And so, what we're going to do today is we're going to first just take a look at the schema as a whole. And then I would actually encourage you to put the schema away and just listen to this sort of conversation that we can have together, at least through this video here, about what the clues are and what the broader concepts are behind the clues themselves. From there, use the schema. You can go back to the schema. It'll be linked below to basically use it as an opportunity for spaced repetition to review what we talk about here today. So I'm just going to take 1 second and pull up our schema here just for you to take a snapshot of it. All right. So just take a few seconds to look at this and understand the different categories. Again, what we're really trying to decide here is how we can use clues that can tip us off to the cause of aortitis being an infection. All right, I'm going to pull the schema down now, and then we're going to talk through what some of these clues are and how we can conceptualize them as a whole. Now, if you look at a general schema for aortitis, the causes are going to include both infectious and non-infectious diseases. The non-infectious diseases are often going to be autoimmune or autoinflammatory in nature, and the base rate of disease is going to favor these non-infectious causes over infectious causes. However, treatment of these non-infectious diseases often involves immunosuppression. And so before we decide that we're ready to treat somebody with immunosuppression for a non-infectious cause of their aortic inflammation, we have to make sure that there's a very low probability of an infection. This is critical before we give someone immunosuppression because high dose immunosuppression can lead to rapid disease progression if there is actually an infection brewing. Now, this is made even more challenging by the fact that some of these infections that cause aortitis can be quite tough to find. Even though the infection is embedded in a large blood vessel, patients' blood cultures can be negative. And for some of the different infections, we have to think to send the right serologies, which can take some time to return and could be tough to interpret, which is why I'm incredibly grateful for our friends in infectious diseases who can help out with that. However, we can use some clues that exist within the patient's presentation of disease itself to help further frame the probability of an infection or a non-infectious cause. In other words, we're going to talk through what these clues are and specifically focus on the ones that can move the probabilistic needle towards an infectious disease, because when we see that, we're going to have a higher threshold to give immunosuppressive agents, and we're going to hunt for one of those possible underlying infections. So let's talk about what some of those clues are. There's 4 primary categories that we can use as clues. Those are going to include number 1, the patient's tempo of disease. Number 2, elements of the patient's background medical history, right? Some of the background information that we often talk about. Number 3 is going to be the imaging features. And then obviously culture data can be incredibly helpful here. Now, when it comes to the tempo of disease, a more acute onset of symptoms and a rapid disease progression increases the probability of an infectious cause. Many of the non-infectious causes will have a more subacute to indolent disease progression. And so when we see that acute onset of symptoms or a rapid progression on imaging, it increases the probability of an infectious cause. Category 2 is going to be patient factors. And really what we're thinking about is what are the underlying elements of a patient's history that can increase the risk of them developing an infectious aortitis. And those categories can be broken down into 2 big ones. Number 1 is pre-existing aortic disease. And number 2 is whether or not the patient has risk factors for developing bacteremia. Pre-existing aortic disease could include things like atherosclerosis, an underlying abdominal or thoracic aortic aneurysm, recent surgery or trauma, and then in some cases, you may see an underlying congenital malformation. Those pre-existing aortic abnormalities create an environment in which an infection may thrive. For example, infections can infect atherosclerotic plaques, or there could be abnormal blood flow through an aneurysm that could increase the risk for a bacteria setting up shop there and causing infection of the aorta. And then, of course, right, infections in the aorta are going to be much more likely in individuals who are bacteremic, right? So if somebody has underlying injection drug use or underlying immunocompromise, those both increase the risk for bacteremia. And so that will also increase the probability of an infectious cause in a patient who has aortitis. Next, we come to imaging. And the imaging findings can oftentimes be the most helpful in framing an infectious etiology against a non-infectious etiology. Some clues to remember on imaging that can help tip the scales towards an infectious cause include eccentric aortic involvement. That means that there's patches of the aorta that's involved as opposed to circumferential involvement. Infections often tend to cause patchy eccentric aortic involvement, whereas the non-infectious causes could be or are more likely to be circumferential. In other words, there's inflammation of the entire aortic wall rather than just a piece of the aortic wall. In addition, infections are much more likely to chew through and erode through the aortic wall, which can lead to weakening and, as a result, outpouchings of the aortic wall. So if you see saccular outpouchings along the aorta, that also increases the likelihood of there being an infectious cause of your patient's aortitis. Two other ones include the presence of air within or around the wall of the aorta, which makes sense because we can think about sometimes there being gas-producing organisms that cause infections. And so infections that set up shop in or in the aortic wall can cause the development of air within or around the aortic wall. And in the same way that infections can lead to the development of air within the wall of the aorta, they can also lead to fluid collections within or around the aortic wall. So again, those imaging features are going to be eccentric involvement, saccular outpouchings, and then intramural air or fluid surrounding the aorta itself. And then finally, obviously, if somebody has positive blood cultures, that's going to drastically increase the probability of the cause of their aortitis being an infection. Now, are all of these clues perfect? Of course not. There's never or rarely any hard and fast rules in medicine. A non-infectious aortitis could have an acute presentation. Just because someone has risk factors for bacteremia doesn't mean that bacteremia is driving their current illness. You can see aneurysmal dilation in individuals who have a non-infectious aortitis. And then sometimes blood cultures can be falsely positive, or someone may have an underlying non-infectious cause and bacteremia alongside that, right? So none of these clues are going to be perfect, but we can use these clues to help weigh the probability of an underlying infection. And we can use those to reason towards the probabilities to the best of our ability, which can help us work through these cases and hopefully decide how far we have to take the infectious workup before we either discover an infectious cause or settle on a non-infectious cause. So I'm just going to pull up our schema here one more time, just for us to walk through this again quickly and solidify any final primary concepts here. All right, so again, as we said, clues to an infectious aortitis, none of them are going to be perfect, but they can help us move that probabilistic needle towards infection. And the four categories we use are tempo, patient, imaging, and culture. And here are some of those things within each of those categories that you can use to help weigh the probability of a non-infectious cause over an infectious cause. Again, please take your time to digest this content and practice quizzing yourself using space repetition by either reviewing this schema on your own or using this schema as a teaching tool or a studying tool as you think through cases of aortitis that you may come across in your own clinical practice. All right. Thanks so much for tuning in. We'll see you next time.